Pancasila. Good morning and warm welcome from Indonesia, the Honorable Dean of the Faculty of Pharmacy Universitas Pancasila and FIC, the Honorable Speaker and Moderator of International Guest Lecture today, and the Honorable all participants joining us online in this guest lecture today. Before we begin the opening ceremony, allow me to introduce myself. My name is Amalia Zahra Apriliana as the Master of Ceremony today. This is a grateful opportunity for all of us. As we know, around a month ago, we just had the first series of international guest lecture with topic pharmacology and clinical pharmacy. And luckily, we have another series of international guest lecture with topic social and administrative pharmacy, focusing with health economic in asthma management. And of course, we are so excited to hear our speakers to discuss this topic with us. But before we begin our agenda for today, allow me to read the rundown for today's agenda. Okay, our rundown for today is the preparation and registration that we already do that. And then we continue to the welcoming session and introduction. After that, it's going to be Indonesian National Anthem and Hymn of Universitas Pancasila. Up next is speech from Professor Dr. Apoteker Syamsuddin Magister Biomedik as the Dean of Faculty of Farmasi Universitas Pancasila. And then introducing moderator for today, Profesor Dr. Apoteker Yusi Anggriani Magister Kesehatan as Head of Center of Pharmaceutical Policy, Management and Services Studies, Faculty of Pharmacy Universitas Pancasila. And then is the main event of our agenda today is guest lecture from Professor Dr. Tan Siang as the Dean of School of Pharmacy, KPJ Healthcare University, Malaysia. And then Q&A session and certificate appreciation. And after that, information and closing session. That is our rundown for today. And ladies and gentlemen, before we continue to the next agenda, we would like to invite you to sing the national anthem of Indonesia, Indonesia Raya, followed by hymn of Universitas Pancasila. For all participants, please be seated properly.
Universitas Pancasila, tetapkan hati masa depanmu secemerlang mentari. Tetapkan hati para dosenmu berjuang untuk keberhasilanmu. Dari kampusmu kau kan sebarkan ilmu. Dari kampus pula kau himpun ilmu. Kau tegakkan, kau siapkan, kau hadapi masa depan. Memperoleh pengetahuan dari taraf yang tinggi. Di sana untuknya dituntut namamu. Di sana untuknya dituntut baktimu. Jangan kau siraukan dunia ini. Langkahkan maju, tundukkan rintanganmu. Hanyalah satu tugas kuliahmu. Manfaatkanlah diri untuk sesamamu. Dari sini ciptakan dunia aman damai. Dari sini ciptakan dunia aman damai.
Thank you. Up next, we would like to invite the Dean of Faculty of Pharmacy of Universitas Pancasila to give a welcoming speech and opening remarks. To the Honorable Professor Dr. Apoteker Syamsuddin Magister Biomedik, the time is yours.
Thank you, Amalia Zahra. Good morning, everyone. The Honorable Professor Siang as speaker. The Honorable Professor Dr. Yusi Anggriani as moderator. The Honorable lecturer, student, and all participants. As the Dean of Faculty of Farmasi Universitas Pancasila, I highly appreciate for the presence of Professor Siang as Dean of School of Pharmacy, KPG Healthcare University Malaysia, and speaker in international guest lecture. Nice to meet you, Professor, even by Zoom. This international guest lecture activity is one of series of activity in the framework of Faculty of Pharmacy's 61st anniversary or Dies Natalis 61st. This activity's topic, health economic in asthma management, is essential in providing broader perspective and understanding for the student, especially in the field of social and administrative pharmacy. I hope that all participants can take advantage of this moment to continue to explore knowledge from the speaker. Finally, I truly hope that this guest lecture will provide new insight, inspiration, and deep and profound understanding for all of us. I would like to invite the participant to actively participate, ask questions, and discuss during the lecture. Let us welcome this guest lecture with great zeal and enthusiasm. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Professor Dr. Apoteker Syamsuddin Magister Biomedik, for the wonderful speech. And then up next, before we continue to the next agenda, it's a photo session first. So for all participants and audiences, please turn on the camera. All right, I'm gonna lead the photo session in 1, 2, 3. For the next slide, in 1, 2, 3. All right, that's all. Thank you so much for all participants who kindly turn on the camera. Now we move on to the main event of our meeting today. As our Dean said, that social and administrative pharmacy is indeed an important aspect of the field of pharmacy. This discipline focuses on the social, behavioral, and administrative aspect of pharmacy practice, emphasizing the relationship between the pharmacist, the patient, the broader healthcare system. And because that, our topic today gonna be so interesting. Health economics in asthma management. But why social and administrative pharmacy is considered too important? It will be answered today. But before we begin our lecture, I would like to introduce the moderator for today, Profesor Dr. Apoteker Yusi Anggriani, Magister Kesehatan.
Thank you very much, Amalia, and all the distinguished Professor Ching Siang. Welcome to our university, Universitas Pancasila. Very good mornings for all distinguished participants here, and I'm honored to address this, to have opportunity to address this event. So as mentioned by the Amalia before, social and administrative is one of the important topic in the healthcare system. So we are glad to have Professor Ching Siang to deliver speech about the pharmacoeconomic in healthcare system, especially on the asthma management. However, before we learn about the social administrative pharmacy in the special topic of the pharmacoeconomic, I would like allow me to present the curriculum vitae of Professor Ching Siang. Please help me to present the curriculum vitae. Yeah. Yeah. So this is the curriculum vitae of the Professor Ching Siang. He is a professor at the KPG Healthcare University. For the bachelor's, he was graduated from the University of Malaya, and for the master and postgraduate for master and a PhD, he graduated from the University Science Malaysia. That is the same university from mine. That I know that in the 2012, we are in the same department but different room, and I ever seen Professor Tan's in the similar supervisor, right, with Professor Asrul Akmal Safi and Prof Asmi. So very glad to have you here, and I know that University Science Malaysia, one is of the leading university for the pharmacoeconomics, and then Prof Tan's have many experience on that, and then he also acts as the dean in healthcare, KPG Healthcare University, and then also acted as active editor board in many journals and related to the social administrative pharmacy. So I believe today we can get many information from Professor Ching Siang about the pharmacoeconomic in the healthcare system. Now I would not too long my speech as a moderator, so you have 45 minutes to deliver the speech, and then this time for yours, Professor Tan. Thank you.
Okay, thank you, Professor Dr. Apoteker Yusi Anggriani. Thank you for your kind introduction. So good morning. First of all, I would like to greet the Dean of Faculty of Pharmacy Universitas Pancasila, Professor Dr. Apoteker Shamsuddin. That Professor Dr. Shamsuddin are very hardworking. That since last year, 2 years ago or last year, that Professor Dr. Shamsuddin has been communicated with me for this collaboration, including this research collaboration and also some clinical part as well. that. So I saw submitted to the management approval that it will be in this progress. Yeah, in the pipeline as well. Yeah. Okay. And then thank you, Professor Dr. Apotheker Yusi Anggriani, as the head of the Center for Pharmaceutical Policy, University Pancasila. And then I believe that Professor Dr. Yusi Anggriani has a very vast experience in the pharmaceutical policy, including the health economic as well. And then I would like to also thanks to the MC, Miss Amalia Anjala. Okay, so and then thank you for the University Pancasila for giving me an opportunity to share this health economic in asthma management today. Okay, so allow me to share my screen. Yeah. Okay. I will share my screen. Okay. Okay, just a minute. Okay, so can every one of you view my slide? Yeah, okay. Okay, so and good morning to all the lecturers, participants, and also the pharmacy students. Okay, for today's topic, right, what I will share is about the health economic in asthma management. Okay, so compared to these lectures that you have been following, like the previous your international guest lecture about the clinical pharmacy. So for today's topic will be a bit different. This is about the health economic in asthma management. It will be a definitely interesting topic that the pharmacists not only emphasize on the clinical knowledge, but together we combine with some health economic calculations of the monetary of other utility as well. Okay. So I move to the next slide. Okay, can you see my second slide? Is it movable?
Yes, it is, Prof.
Yes. Okay. So for my sharing today, right, that the learning outcome that the participants, the audience will understand the knowledge about the basic principles of the health economics. So I will introduce what is a health economic as a general and their application in asthma management as well as in any clinical management as well. And today I will focus on the pharmacoeconomic in one of the particular element that is a cost effectiveness analysis in asthma management. Okay. So I believe that based on my personal experience as well, like sometimes bachelor of pharmacy student, right, sometimes quite a tough and also challenging following the clinical pharmacy, and then you have a many pharmacology medical terms to memorize. Okay, for health economic, right, it will be interesting that it will involve many calculation. That it is a very flexible dynamic that you can apply many of this literature information, fact formula, so that you will be making this topic more interesting and you can apply in your upcoming research as well. Yeah. Okay. For the health economic, okay. For today, we will emphasize on the cost effectiveness study. Okay. So in short, we call it as a CEA. Okay. So for today, my sharing, right? Okay. So I will talk about this CEA on this respiratory medication therapy adherence, RMTech. Later, I will tell what is a MTech. Okay, compared to this traditional physician's care. Okay, plus this physician's care alone. Okay, and then I also will talk about this economic evaluation study on this cost effectiveness, like in other management as well. Yeah. Okay. So later, moderator, feel free to alert me if let's say the time is almost finished. Yeah. Okay. So in globally, we can see that many researchers they apply this health economy in this research study. So one of the famous just now Professor Dr. Apotheker Yusi Anggriani mentioned, Professor Dr. Ashro. He is the master of the health economy in Malaysia. That he also one of my Yong is one of my friend as well from USM, master of pharmacy in USM. That they also conducted one of the study in evaluating how these efficiencies of the respiratory medication therapy adherence screening on asthma patient in Malaysia by using the Markov model. Later, I will show you in some detail. Okay. And then in another study, we can see that another study on cost effectiveness analysis of fluticasone. Okay, so pharmacy student, do you know what is a fluticasone? It's one of the corticosteroid versus the montelukast singulair in children with mild to moderate persistent asthma in a pediatric asthma control trial. Okay, so we can see that in this trial, they are comparing both the fluticasone and also montelukast in controlling the asthma. Okay, so in this cost-effectiveness analysis, right, later we will see, I will tell you that what are the components that we need to take consideration. Okay, in terms of the efficacy of the medication, we also take note on the side effect, the cost of medication. So total, how much of the cost, and at the same time, we will see that the effectiveness compared to alternative. Okay. So another example, cost effectiveness of pulmonary rehabilitations in patients with a bronchial asthma. So in fact, the researcher also collaborate with the other healthcare professional, like for example, physiotherapists on this health economy for this bronchial asthma as well. Okay, and then many example of this topic on the asthma as well. Okay, like for example, this is a cost effectiveness of internet-based self-management compared with the usual care in asthma. Okay. Okay, so let me start with the background, the introduction of the economic evaluation. So economic evaluation is a systematic. So we need to follow some guideline, some step. Okay, explicitly analysis of the alternative causes. Definitely, there will be the true comparator. So that's why we want to compare which one will be more important, which one will be more significant. Okay, at the same time, right, we will have both cause and consequences. Okay, later I will show you. Okay, and then bear in mind that the pharmacoeconomic evaluation is the use of the economic evaluation in the pharmaceutical sector that sometimes the government sector, they want to consider whether they want to take a new medication into their formulary book compared to the existing medication. Okay, although the new medication definitely with the new technology will be more expensive. Okay, so at this point, right, they will evaluate, is it the new medication with more expensive but lesser side effect, lesser complication. In the long run, is it will be safe and provide better effectiveness to the patient. Yeah. So the important point is that economic evaluation is not about choosing the cheapest. Not to say that this is the cheapest medication, this is the best. But we will see that which will be the price, but it will give the verdict effectiveness. Okay. Like for example, okay, influence of the compliance with the medication on cost effectiveness. If we will measure, if let's say the patient with a full compliance to achieve the blood pressure with this 105, then it will incur price of this. But if let's say partial compliance, that we will have a more complication. Yeah. Similarly with the diastolic part. Okay. And this is an overview of the economic evaluation that not just about the economy. Okay. Economic health evaluation, right? Okay. There will be advantage for the pharmacist, apotheker, because we know about the medication. We know about the side effect, the complication of medication. So now what we need to do is that to apply some economic formula into it so that we can see the overview of the disease management. So health economic, we also include economic, the cost effectiveness analysis, epidemiology, because we need to apply the probability, the prevalence, etc. So in short, I can summarize that the economic evaluation, right? The important thing is that we need to have a two. One is about the cost. One is about the cost. One is about the consequences. Okay, so we want to see that whether the cost we apply, is it will provide any of this effectiveness or the consequences as an outcome of the comparators. Okay, and then in the form of evaluation, right, we have a very superficial, like very preliminary, just measure about the costing, means that just about the cost only. Okay, so it will be fall under here. Okay, and it can be a very thorough full economic evaluation that it will be for both costs and consequences. Okay, I will show you an example shortly. Okay, and for the full economic evaluation, it has been we have a four major category. There is a cost minimization, effectiveness, cost utility analysis, and cost benefit analysis. Okay, so come to this partial or no evaluation, right? So perhaps we can focus on the front part here. That is about the cost. So you can see that just about the cost only. Yeah. Okay. So what I would like to share that last year, okay, I also presented one of the research topic that is about the cost of acute stroke care at a private hospital, perspective from the patient perspective. Okay, so here is actually I assign my final year students went to the KPJ hospital. Okay, so we take advantage of this hospital data that I assign my this final year pharmacy student go to the medical office, data office to correct the whole year 2022, the whole year stroke patient, and then we will analyze all the costs. Okay, how much of this ward charge, and then consultant fees, medications, nursing fees, physiotherapies, laboratory fees as well. Okay, so this will be a very good costing fees that we can analyze to the management as well as to the researcher, as well as to the policymaker as well. Okay, so this is we call as just about the cost analysis. Okay. Okay. So at the same time, if let's say we want to go further, is more detail, there is a full economic evaluation that it will evaluate both. One is the cost, another one is the effectiveness. Okay. So come to the cost and the effectiveness, right? We can draw a diagram here. Okay. So basically, what we can do is that this line is about the cost, and this line is about the difference in the effect. Okay. So eventually, right? Eventually, what we measure, if let's say the category is fall under here, then the new medication, the new treatment is a more effectiveness and more expensive because here are both positive here. Okay, because positive, okay, this is a negative part, this is a negative. Okay, so if let's say fall under here, right? Number 2, the new medication is more effectiveness because this is a part is the effectiveness, but less expensive. So definitely we will choose this. Okay. And then for the number 4, the new treatment is the less effectiveness and more expensive. So definitely we will not choose this. Definitely incur more costs, but less effectiveness that we will choose not not to consider this. Okay. If the new treatment is the less effectiveness and less expensive, we may consider as well. Okay. But usually, right, the new medication will be fall under category of section 1 here. There is more effectiveness and more effectiveness. So that's why we need the health economic evaluation to see how much additional cost we need to pay for the additional effectiveness. Okay, as I mentioned just now, okay, we have the 4 main category of the health economic. Okay, so basically we can ignore this cost of illness. That is just I mean the cost of illness is what I mentioned to you. We just measure about the cost only, didn't measure about the outcome. Okay, but for the following of these 4 main category, there is a cost minimization that we will measure in the monetary, but we assume we need to make sure that the two comparator in terms of the outcome, they have the equivalence in the two groups. Yeah, okay. And for cost benefit, both cost and outcome, we will measure in the monetary. Okay. For the cost effectiveness analysis, that we will measure the cost part as a monetary, but the outcome unit we will measure in the natural units or the unit of effect. Like for example, you have a two alternative product A and product B, drug A and drug B. Okay, do you want to compare drug A and drug B? Which one can control better for the blood pressure? For the blood pressure. So let's say product A can reduce 5 millimercury. Product B can reduce 10 millimercury. Okay. At the same time, you will measure product A and B about the complication, their side effect. Definitely the side effect, what is the percentage of develop it? Okay, and then how much of the cost you need to give as a treatment. Okay. I will show it in the later example. The last one is about the cost utility that similarly, the cost unit part will be the monetary, but the outcome we measure as a quality adjusted life years. Okay. So for today, I will focus on the cost effectiveness part. Yeah. Okay. So this is a clearer picture for you to understand that the input, right? So the input usually we will be seeing that the cost, okay, the output we can be any motility, any measurable part. Yeah. Okay. Okay. Come to the cost, right? We need to consider many perspective of the cost. Like in the health economy, we have the direct medical and also non-direct medical costs. Direct medical costs, right? Okay. We have the direct medical costs, like for example, the consultant fees, the doctor fees, admission fees, the ward fees, laboratory fees, cost of adverse reactions, like for example, once the patient take the medication and develop dry cough, that you need to give additional cough mixture, that this is the cost of adverse event as well. Okay. Non-medical costs, including transportation, like for example, the patient need to take transport through the hospital. Okay. And then indirect costs, including, like for example, the patient after discharge from the ward, they cannot go to work, MC for 1 week, and then at the same time, maybe they lost of their job due to the inability, for example, for the stroke. Okay. And then the last one, we also measure, we call it as an intangible cost, like for example, pain, the happiness, the quality of life. Okay. Okay. This is the costing part, the cost part. And then this is the consequences, the outcome. The outcome, it can be a monetary, as I told you, and then it can be any effectiveness, quality as well. Okay. Okay, quality. So this is that measuring within the whole 1 year. That how happiness, how the quality of life within the 1 year for the patient. So usually we will be measure from 0 to 1. Okay. Yeah. Okay. So for today, we will focus on the cost effectiveness. Cost effectiveness, and we will use this formula by putting cost of treatment divided by the therapeutic effect. Right, for example, that in the blood pressure controlling I mentioned just now, like for example, um, the medication can reduce 5 mg mercury of the blood pressure. Then we will divide by using how much of the cost, like for example, it will be USD about $2, $20. Then we will get a one value. Okay, so this is, we call it as the cost effectiveness ratio. Okay, so the average cost effectiveness, right? So this is by using this formula, cost divided by the therapeutic effect. So similarly, if let's say you measure for the diabetes, okay, so you measure the HbA1c, HbA1c. So how much of the HbA1c that it can be reduced? Okay, even though you can also measure the successfully rate of the therapy. Okay. Okay. And then once, because we have the product A and B for the CEA. Okay. Next, we will use this A and B, the CEA, by measure to calculate the incremental cost effectiveness. We call it as ICER. The ICER. So means that the ICER will be product A minus product B. Okay, let me show you. Okay, this is one of the example with the treatment A and treatment B. Okay, the total cost for treatment A, let's say, is a 325. Treatment B is a 450. Okay, the successfully rate, this it will be the 87%. Treatment B will provide 91%. Okay, and then okay, the average cost effectiveness, as I mentioned just now, this cost divided by the therapeutic effect. Okay, so similarly, we apply the same formula by using cost divided by the effectiveness in measure with the successfully rate. So 325 divided by the 0.87. Okay, then we can get 373. So means that we need to pay 373 ringgit, $373 per every successful case. Similarly, for treatment B, you need to pay $494. Okay, come to the incremental cost effectiveness. We apply the same idea by using, we see which one will be the higher price. So in this case, we use the treatment B minus treatment A. 450 divided by 325 and divided by the successfully rate of 91% minus 87. So we get this figure. So we can make conclusion that we need to pay $3,125 for additional of successful of the treatment therapy. Yeah. Okay. Then, okay. So before we go for, okay, this is the calculation part. Okay. The CEA, right? We need to follow the step. The first step, definitely, as I mentioned just now, that we have the true therapy, the alternative therapy. Usually we have the drug A and drug B. Okay, so usually we have one is the newer therapy. We have the new therapy. Okay, let's say this is the assisting that we are using in the hospital. We are using in the hospital. So now the management of the hospital management, they want to consider whether the drug A, is it worth it or not? with a more expensive price compared to the existing drug B in the hospital. Okay, so from here, we need to develop, we call it as a decision tree analysis. Okay, so from here, we need to measure what are the costs and the benefit as well. Okay, similarly, the existing one, we also will consider the cost and also the benefit. Okay, so from here, we need to develop a one decision tree. Okay, so in the decision tree, sometimes we call it as a decision analysis as well. Okay. Okay, so in each of the decision, right? Like for example, okay. So for example, antibiotic A and also antibiotic B. Okay, so antibiotic A, let's say this is a new medication. Okay, this is a existing. This is the old medication existing. Okay, okay, antibiotic A, the clinical successful and also the clinical failure. Definitely. Okay, so what we can get this percentage, right, is from the literature or from a randomized control trial or the meta-analysis from the literature, from the journal. Okay, so let's say that we have gone through all this literature, and then we found out that the successfully rate for, let's say, maybe we say that the new medication, just an example, vancomycin, vancomycin. Okay, so the clinical successful, let's say, is a 90%. So the clinical failure will be 10%. Okay, what are the adverse events? Okay, but for example, the severe one, red man syndrome or the kidney failure. Okay, let's say this will be the 70%. Okay, this is a 30%. So we fill up all this in the decision tree. Okay, similarly, when you're assisting, you also fill up. Okay, in this decision analysis, right? Okay, there will be some guideline standard we need to follow. So if let's say there is some alternative part, right? We need to put a circle here. Okay, so if let's say this is the end, this is the end, then we put a one triangle here. Okay, the concept here, right, means that, like for example, MRSA infection, methicillin resistant Staph aureus. Okay, so let's say this is a vancomycin, this is a linezolid. Okay, the clinical successful, definitely all the antibiotic either will successful or failure. At the same time, the clinical successful, you will have a adverse event or no adverse event. Similarly, those failure patient, right, still same, they will facing adverse event as well or no adverse event. Okay, compared to the existing drug, clinical successful or failure, same, they will facing the adverse event as well. Okay, so from here, I give you an example, antibiotic A and antibiotic B. Okay, the probability, the percentage of the clinical successful, let's say this is a 90%, this is 80%. Okay, the percentage here, right, we can get from the literature. The powerful or the evidence will be from the meta-analysis research study. Okay, otherwise we can use the randomized control trial. Okay, then the cost of the antibiotic. Okay, let's say A is 600, B is 500. Okay, and then we also, the probability, how many percentage that A and B will develop the side effect. So similarly, you can get this percentage either from the drug company or from this literature as well. Okay, and then the cost of treating adverse event. Okay, so this is the tedious part, that you take the significant adverse event. Like for example, if you occur um, 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 renal failure, ototoxicity, nephrotoxicity, etc. And then the cost of treatment, the kidney failure, dialysis, how much? And then the cost of treating, let's say, the red man syndrome, how much? Okay, so how much? Let's say it's $1,000. Okay, so from here, right, because we need to get this information, later we need to sum up the total cost. The total cost will show you usually will be by using cost multiplied by the probability. This is a formula. Okay, so remember I show you the previous diagram here. Okay, so now once we get this all the information, we need to label it. We need to put it into the diagram. So just now, antibiotic A and antibiotic B. Okay, so antibiotic A, the clinical successful 90%, 10%. Adverse event 90%. No adverse event 90%. Adverse event 10%. Okay, so we put it, we properly label here. Okay, and then we understand that the cost of antibiotic for antibiotic A is a 600 ringgit, or is a 600 ringgit. So we put it here, 600, because in this alternative, right, antibiotic A, clinical successful, okay, no adverse event. So means that we no need to treat for the adverse event. Okay, so we only pay for 600. Okay, here, the second part, because the patient will develop adverse event, so we need to consider the 1,000 ringgit. So here we means that 600 plus 1,000. So it will incur 1,600. Okay. Similarly, clinical failure, like for example, the patient admitted to the hospital, clinical failure, you need the patient still need to pay to the hospital as well, because the hospital site has been provided the medication, although it's failure. Yeah, 600 and 1,006, because it need to incur the cost for treating the adverse event. Okay. Similarly, for antibiotic B, the cost of antibiotic B is 500. So here, no adverse event, 500. With the adverse event is 500 plus 1,000. Okay, so 1,005. So we apply the same concept here. Okay. Okay, I hope that all the participants can follow until here. Okay, now next, we need to generate a one table. So the cost of antibiotic, right? So we will put divided into the antibiotic A and also antibiotic B. For antibiotic A, right? So successful with no adverse event. It refer to here. It refer to the here. 600. Okay. Then, okay, the first part, so means that the probability if it's 90% times 90%. It come on the formula here. 90%, 0.9 times 0.9. So we get about the probability about 81%. The patient will only incur the antibiotic cost only. So it will give the cost of 486. Okay. Second possibility, this is a second. Okay. 0.9 times 0.1. This is a part. So because involved with the adverse event, so 600 plus 1,000. So it incur 1,006 times 9%. Then we get 144. Okay. So eventually we calculate all the possibility. 1, 2, 3, 4. The 4 possibility here. The 4 possibility here. Then you can get this amount. So eventually the sum amount is 100%. So you can, the possibility for the antibiotic A is about 700. Okay, so that's why we can see that 700 is here. Okay. So similarly, we apply the same concept to the antibiotic B. Okay. So we calculate the possibility of from scenario 5 to scenario number 8. Okay. Then we get the sum is total 650. Okay, so this is the 650. Okay. Okay, so this is the decision tree and also calculations on all the this costing. Okay, so this is the part that I told you that the adverse event. Adverse event, all the possibility, the cost, it will be a very tedious task that you need to read all the literature that what are the related most significant side effects of the medication and the treatment cost. Okay. Okay. So here we can make a one summary that antibiotic B, or the antibiotic B, this is antibiotic B, 650 is a less expensive by including the cost of treatment adverse event. But because antibiotic A have a better clinical option. Why? We can see that the clinical option is 90% compared to the antibiotic B, only 80% only, the successful rate. Well, means that for the 10 patient, antibiotic A can cure 9 patients. Antibiotic B only can cure for 8 patients only. Okay, so definitely A will be better, but A is more expensive. Okay, so that's why we calculate the ICER that I show you just now by using the drug A minus drug B, the cost, and then at the same time, the effectiveness, the outcome from 90%. Okay, sorry, there is some typo. Typo should be 90%. Okay, minus 80%. Okay, so in summary, the conclusion we get is that in order to adopt antibiotic A, right? The management, they agree that they need to pay $500 more per extra successful. Okay, so if let's say they feel that, oh, 500 for most another successful, right, is worth it. At the same time, we can treat the patient earlier, more successful, and then the patient can discharge earlier from the hospital, and then we can save the pace of the ward, the patient bed, and we can get more new patient as well. So it's worth it. Okay, then they can adopt the antibiotic A into their formulary. Okay, and then another step, the following step is that we need to conduct a one sensitivity analysis. Okay, so the sensitivity analysis, right, usually we will be calculated by using Excel sheet, or it's a simple way. And then the sensitivity analysis, basically the purpose is that because all of this calculation, right, we are putting the assumption, we assumption. So we want to make sure that all this assumption, the uncertainty, right, is a solid, that is can be trusted. That at the same time we will put all this high and low estimate of the cost and the probability in the decision model. Okay, let us see. So from here, so usually we will get this from the management or this drug company, that what are this low estimate and high estimate. So at the same time, the cost of treating adverse event, what are the highest and the lowest. Okay. Okay, then we will put it the antibiotic A and antibiotic B here. Okay, so just now we mentioned that it will be 700 and 650. Okay, so from here we put the estimate highest and the lowest. Then we can properly calculate that how much it will be cost for the following. Okay, instead of we just put a one figure here, we will put a lower ledge and higher ledge so that our research is more solid and robust. Okay. So here we can put a 1 overall costing A minus B. Okay. But bear in mind that here in the one column here, right, for the probability of the adverse event for antibiotic A. So let's say from the later lectures that the lowest will be the 7% and the highest is 15%. We notice that here in this column, right, both also provide the positive value compared to the others, right? It will provide the alternative, which one will be more expensive, which one will be the less expensive. But for this probability of adverse event for antibiotic A, okay, both also in the range of the positive. Okay, so means that the A is insensitive or is insensitive through the when the moment we conduct this sensitivity analysis, that we will not consider this portion here. Okay, so once we have to analyze all of this cost, right, we will put it into the tornado graph. It's one of the, we can generate from the Excel as well, that what are the costs that will be sensitive to your analysis and is a more related and significant impact to you. Okay. So the standard we need to follow is that the range that has the biggest impact on the answer is placed at the top of the graph. Okay, and then the rest will be appear in the descending rank. Okay. So we put all this significant one, especially the biggest impact, on the top here, and then the last one will be at the bottom here. Okay, so in this case, right, the cost of our adverse event is about 500 to 2,500 that we will be putting here. Okay, so B, okay, and then this one be just omit for the cost, for the adverse event A. This one we omit because it's insensitive. Okay. Okay, let me elaborate again for this asthma topic. Okay, let's say come to the CA on this asthma. Just now we have learned that how to conduct the CA. Okay, so come to this asthma, how we can apply the CA on the asthma. Okay, so all the introduction, like for example, in the globally we have the many of the asthmatic patient. Okay, and then the increment, the case increased tremendously yearly. Okay, and then it is due to the acute airway inflammation and obstruction as well. Okay, and then the severity. Remember, we follow this GINA guideline that the asthma treatment we can be classified into the mild, moderate, and severe. Okay, so that's why I mentioned at the beginning that pharmacist is the more, is the appropriate healthcare professional to carry out the health economy, because we learn about all this epidemiology. We have this pharmacology, the clinical pharmacy knowledge. We can apply all this percentage. At the same time, we learn the health economy formula. Then we can carry out the health economic evaluation accurately. Okay, so if let's say we follow the guideline, right? Mild asthma is well controlled with the step 1 or step 2 treatment and is estimated to affect about 50 to 75% of all patients with asthma. Okay, so this is some of the local epidemiology in Malaysia. Okay. Now, so I think this is 2017. I think recently GINA just updated the new guideline. Okay, so let's say follow the previous guideline that follow in parallel with the study conducted before. That step 1, follow the guideline. If let's say for the patient, right, in the mild stage, we consider use the low dose of the intracortical steroid. Okay. Similarly, step 2, we also use the low dose, but we can include this leukotriene receptor antagonist and low dose of theophylline. Okay, and both stage 1 and 2, we use the SABA, short-acting beta agonist, like for example, Astalin, okay, Ventolin. Okay, come to the step 3, right? We need to use the low dose ICS, and we can consider low dose of the intracorticosteroid plus the long-acting beta agonist, LABA, formoterol. Okay, right. Okay, so I would like to share with you one study that I also involved in the part of this calculation as well. This is to compare whether that Symbicort, is it Symbicort use of this budesonide formoterol as needed symptom driven in the mild asthma treatment therapy. So means that now we want to propose to your hospital management whether step 2, is it okay that we plus this ICS plus LABA. That is a Symbicort, okay? A budesonide plus formoterol. Okay, so what is the economic impact? Okay, is it in the long run? Because we understand that budesonide, formoterol, Symbicort, overall the pricing of the product is higher compared to the traditional intracorticosteroid plus the short-acting beta agonist, like for example, Ventolin. Okay. But if let's say the Symbicort in the long run can control well the complication, prevent the reoccurrence of the acute attack, then it will be safe. It can reduce the patient hospital admission, at the same time reduce this side effect as well. Okay, so this is one of the study that published in 2021. Okay, that cost effectiveness analysis of budesonide formoterol Symbicort as needed for mild asthma in Malaysia. Okay, so we can see that the health economic, right, is a very interesting that not only we focus on the clinical parameters, but we also will involve with some costing as well. So in this study, right, in the health economic, not necessarily that researcher need to go to the hospital to have a data collection, but we can get this clinical trial or this clinical trial randomized control data. Like for example, here they adopted the Sigma 1 and Sigma 2, and also the novel start clinical trial data that put it as the percentage of the adverse event, the percentage of the admission as well. Okay. Okay, let me show you in the detail. Okay, so in this study, right, the budesonide, okay, the budesonide formoterol using is 160 over 4.5. Okay, okay, and then they will be using this Symbicort when necessary. Means that here they will be putting here to replace short-acting agonist. So they want to use it as when necessary, PRN. Okay. Okay. Compare. Okay, so this is the option 1. Okay. Compared to the salbutamol, the traditional way that the short-acting beta agonist salbutamol, 100 microgram. Okay. And then at the same time, they also compare to the maintenance of the budesonide, intracorticosteroid, twice daily plus salbutamol when necessary. Okay. So these are the three comparators: Symbicort when necessary, SABA when necessary. The third is budesonide plus SABA when necessary. Okay, and then both also will provide the same severe exacerbation or no severe exacerbation. Means that if let's say severe exacerbation, it will be proceed to the stage 3. It will be proceed to the this step 3. That it will be incur more cost. Step 4 as well. Okay, so same, if let's say we use short-acting beta agonist, it also have a same possibility here. So that's why it mentioned branches as above. Okay. So this is be the decision analytical model. Okay. Okay. The cost input here. So they will put it as the payer perspective in this study, right? So because the company want to propose to the Ministry of Health that to adopt this Symbicort into the stage 1 and 2 in replace of this SABA as when necessary. Okay, so in this health economic, right, we need to determine who is the payers, who is in which perspective. Yeah. Okay, and then here they also need to key in the drug acquisition cost, the cost associated with the management of the severe exacerbation at the emergency department or the inpatient. Okay, because it will be incurred with these consultants, nurses. Okay, cost of the schedule, clinical visit as well. Okay, so all of this data, right? So the researcher, they can get it from the hospital or from the literature. If let's say literature cannot get right, then they can get the expert opinion, the data. Okay, the expert panels estimated that 80%. So in this case, right, because the researcher have some challenging to get this accurate this percentage from the literature, then they will get this expert opinion. In this case, they obtain the opinion from the pulmonologist, the respiratory consultant. So the respiratory consultant, they mentioned that it's about 80% of the patient with a severe exacerbation would require a hospitalization, and another 20% would adequately manage in an emergency department. So this will be properly addressed that what are the complications if let's say the patient have an exacerbation here. If let's say they develop the severe exacerbation. Okay. So patient with a good symptoms control and no severe exacerbation would have an average of the 3 clinic visit a year for disease monitoring. Okay. Then all this data, right, they obtained from this clinical trial. Okay. The clinical trial. And then the maintenance, how much? And at the same time, the clinic visit. Okay, how much? Like for example, they take the average. If let's say someone has published before, then will be good, especially with the local data. They can adopt the local data for their for their study. Okay, and then the drug, how much? Like for example, salbutamol about 6 ringgit 20 cent only in Malaysia, and then budesonide formoterol, the Symbicort about 70 ringgit. Okay, and then with no severe exacerbation, so we need to accurately key in all this data. Okay, then we can do the comparison, the cost component of the mild asthma treatment for each of the comparators. Okay, so the first option, Symbicort, true SABA only. The third is a combination of the ICS plus SABA. Okay, the drug cost for Symbicort, the average about 111 ringgit Malaysia. SABA 5 ringgit, and the combination ICS and SABA 59. Okay, so the disease management with no severe exacerbation. Okay, if this applies, so same. So the total cost will be with the no severe exacerbation about 600. and then Sabah about 524. Combination will be 576, 78. Okay, with a severe exacerbation because the patient need admitted to the ward, maybe about 2 to 3 days hospitalization. So that's why it will be incur more cost. So definitely the Symbicort will be higher. Okay. Okay. Now next step. So in here, you also need to properly cited where the data you obtain. Like for example here, they obtain from the clinical trial sigma. Okay. The proportion cost, right? Okay. So here, remember the decision tree. Okay, the decision tree. Then they put it all this probability into the decision analysis. So from here, then they can generate the total cost. Okay, first of all, they will be divided into two. One is without the severe exacerbation. Okay, another one is with the severe exacerbation. Okay, so here, without the severe exacerbation means that only focus on the medication cost only, right? Okay, so definitely, with the medication only, right, without the severe exacerbation, so the Symbicort will be the higher price, 587 compared to the 429 and also 528. But if let's say with the severe exacerbation, right, with the admission to the hospital, hospitalization, consultants fees, laboratory fees, nursing fees, pharmacy costs as well, the Sabah only will be incur higher costs. Do you know why? Because perhaps the the proportional the admission for the Symbicort group, right, will be lesser, reduced. The probability will be better controlled. So with the severe exacerbation, the probability will be lower compared to the others. Okay, so relatively, we can see that the Symbicort part, the total cost for severe exacerbation will be lower compared to the Sabah alone and also the combination of ICS plus Sabah. Yeah. Oh, okay. So we can see that the treatment with this Symbicort, budesonide, and formoterol, 773 ringgit were associated with a reduced total annual cost of the 134 ringgit 88 cents when compared to the Sabah alone. Okay, so at the same time, the treatment with this budesonide and formoterol will necessarily incur a small increment of only about 12 ringgit and 88 annually, if let's say compared to the third competitor. Okay, so we can say that the budesonide and formoterol was associated with the fewer severe exacerbation. Okay, so as such, the treatment with this Symbicort was dominant intervention. So means that more effective and cheaper, that it will be fall under the category of true here over the Sabah when necessary. Okay, okay, and then so this is the tornadogram that I showed you just now. That all the costing need to be putting into the tornadogram. Okay, so all this costing will be properly addressed here. Okay.
Excuse me, Prof. Tan.
Yeah, yeah.
You have more than 3 minutes.
3 minutes, huh? Yeah,
Yes, okay.
I'm putting the summary now. Okay, now.
Okay, thank you.
Okay, thank you, Prof. Okay, so from the dissemination healthcare payers perspective, budesonide formoterol, when necessary, is either a dominant, okay, or likely to be a cost-effectiveness treatment option for the patient with a mild asthma when compared to the Sabah alone or maintenance of budesonide treatments. Okay, so here, and another, so in fact, in the hospital, we also can evaluate, like, to measure that the medication therapy adherence clinic, like for example, in your hospital as well. that the pharmacist give the additional treatment. Like for example, Prof. Asro have done this one, the medication therapy adherence clinic for the asthma. So similarly, they also compare that whether the pharmacist provide additional counseling in the hospital compared to the traditional physicians given the treatment only. Okay, so and then they can see that they will also measure the quality of life, number of hospitalization, and then this decision tree, they are using the Markov model. Markov model is a quite tedious and complicated that it will be recycled, come back again, rather than one way of the decision tree. Okay, and then so they put it all this value. Okay, and then so in the conclusion, they found out that okay, the pharmacists provide the counseling in the hospital, okay, plus the doctor traditional services is more effective and yet cheaper compared to the physicians alone, because we can reduce this patient admission again and also reduce the complication. Yeah. Okay, so take home message that think of the new therapies, services. The new therapies can be medication. The services, like for example, you want to introduce to your hospital that okay, we can provide the additional pharmacist counseling services in the hospital, and at the same time, it's a benefit to the patient and can reduce the patient admission and also the complication. Then you can design a one health economic research study and show to the management. Yeah. Okay. So at the same time, could comprehend extensively the health economic research study and report. Okay. So these are the references book. Okay. Thank you. Okay. Let me stop sharing. Hey, let me stop sharing. Okay. Thank you. That's all for the my sharing. Yeah.
Okay. Thank you very much, Prof. Dan. So I have written the message in the chat forum. So the participant can ask directly to the forum or write in the chat forum. So there are two question here. Can you see the question, or should I read? Because we don't have enough time to.
I can see the message here.
Yeah.
Okay, so first is from the Lulu Fatima. It's about the what are the disadvantage of the CA or compared to the other methods. Okay, so the CA, right? Okay, CA, if let's say it incur more than 1 year, then you need to apply the discounting part. Okay, and at the same time, the CA at one time we only can measure one component only. Okay, okay, and then in the CA part, the limitation is that you need to look for the really significant the data. Because in the health economy, usually we will put a lot of this assumption. We get this probability data from the literature. Okay, and then okay, I hope that I answer for your question. Okay, Ms. Lulu Fatima. Okay. And then the next one will be the franchise. What can the pharmacist ensure that the medication, the most cost-effective when the doctor prescribe expensive brand drug, because pharmacy industry marketing, whereas same drug with cheaper cost assist. Okay, so I believe that franchise is asking about the comparing the innovator drug together with the generic drug. Okay, am I correct?
Yeah.
Okay. Yeah. Okay. So the innovator drug and also the generic medication, right? Okay. In fact, you also can do, if let's say you want to conduct this CA study, cost effectiveness analysis study, that perhaps you can do your own real world study, the local study in your hospital, that for the two group of the patient group, the innovator and also the generic, because sometimes the generic part, their bioavailability part will be not so good compared to the innovator. So therefore, the effectiveness will be, we need to be to be ensured. Okay. But if let's say both also can be equivalence of the side effect, at this point, you can conduct the cost minimization analysis. So means that the both equivalence effectiveness are the same, then you just compare the cost only. Yeah.
So, may I direct you to the question related to the asthma? I think there is one question, two questions. It's very interesting. So the latest we can answer Sadayu Prajna, but now move to the Pajar Ari.
Yeah.
Because it is very related to your presentation, and then to the Leo Tanuwijaya.
Okay, I would like to ask from Prof. So what are the benefits of economic help program in preventing asthma exacerbation and reducing the economic burden associated with the long-term care? Okay, so because health economic, right? Instead of the measuring the clinical parameters outcome, right, is due to the limited resources from the hospital or from the country. Limited resources means that the fund that we want to buy medication, we have the limited. Okay, if let's say with this limited fund, right, or the resources, that we need to make a very wise decision that which medication we need to buy. Now, if let's say in this example, right, in this respiratory asthma exacerbation, if the company or the hospital, they have the extra resources, and then they are willing to pay after we do this incremental cost effectiveness analysis ratio, the ICER, that the hospital agreed to pay additional 500,000 ringgit for additional successful rate, then we can go ahead for that. That in the long run, it can be a benefit to the patient as well as to the hospital as well. Yeah.
Okay, so I'm glad there are so many students and participants here interested with your presentation in asthma. So we can add one more minutes for to answer the question, so the participant can be satisfied for your present here.
Okay, so one more question, is it?
But two, I think it's okay.
Two, okay.
Yeah.
So okay, maybe I come to JC. How does health economic play a role in management of asthma, particularly in terms of the cost effectiveness of treatment and resource allocation? Okay. In terms of the management of asthma, right, for the health economic, so either you can compare this new medication compared to your existing medication in your hospital formulary, or otherwise you can think about this new idea that, or whether I'm not sure that in Indonesia whether has been introduced that the clinical pharmacist services in the hospital, especially at the outpatient, that the M.Tech, the medication therapy adherence clinic, that the pharmacist will provide additional service, counseling, teach the technique, give the awareness to the patient. So from here, we can reduce the patient's side effect and also encourage the patient more adherence to the medication. If we can go for this direction, and then to measure that the additional providing of the pharmacist in the hospital, how much is the cost of the salary? At the same time, compare with the traditional, only the doctor providing the services. So we can compare from these two groups, right? The patient admission to the hospital, the reduction of the hospital admission. At the same time, the complication will be reduced from there. So this is one of the good topic. If let's say you want to go for the asthma management in the hospital. Okay. So next, does the cost effectiveness analysis can use to determine a therapy for emergency patient?
Yes.
Cost effectiveness CEA for the emergency patient. You can either look for any new device or new services or the comparator or new medication. Like for example, you want to introduce like any new device, the defibrillator, the costing, the high expensive services, the tool, the facility in the emergency patient, okay, compared to the existing. Okay, and at the same time, whether any newer medication that can be used in the emergency patient as well, compared to the traditional. Okay. And then
I think the last question is very interesting to answer. I think it's no problem for us if to extend for minutes, yeah, Amalia, because we have to appreciate the participation of the participants. So I'm glad to. This is from TCRs that
Siang.
yeah.
Siang. Okay.
Chesha.
Chesha. Okay. Okay, Chasha, what are the economic implications?
Yeah, compare as the education, early detection, and lifestyle changes in the long-term care of healthcare costs for asthma patients. So, if you have any experience on besides the intervention by the medicine, so maybe see us about the others intervention to manage the asthma. Do you have any experiences on that?
Okay, what are the economic implications of preventing measure in asthma management, and how do interventions such as education, early detections, and lifestyle changes impact long-term healthcare costs for asthma patients? Yeah. Okay. Good. Good. Okay. Good question. Okay. So here, so maybe I think we can see in the field perspective. Okay, so the economic implication of the preventive measure, right? So preventive measure, like you mentioned, that education, awareness. Okay, so in the health economic, right? In the health economic, usually we need to compare for the two perspective, the existing or these are new services. In the new services, like for example, perhaps we can design a field program in the hospital or in this a community pharmacy that you can design a one program or the module that to provide this respiratory asthmatic patient that they need to follow for about 6 months or 1 year. Okay, and then you can compare for this two group of the patient, those without following the pharmacist advice or the education counseling. In the long run, that the asthma, recurrent attack, and also hospitalization, what is the reduction? Okay, so from here you can do some decision tree and then put in all this probability and also the costing. Yeah, so in fact you also can introduce, like for example, this one nebulization services at the community pharmacy compared to the provision only by the doctor in the clinic. Yeah, so these are some new idea that perhaps we can adopt it from the overseas country as well.
Okay. Thank you very much, Siang. So participants, we are so sorry because we are limited by the time, so we cannot answer all the question in the chat forum. But let me have one question from the previous ones. How if the patient doesn't have money to buy the medicine? That's why there is a universal health coverage. For people in Indonesia, for people who doesn't have money to buy the medicine, so they can become as a member for the universal health coverage. We call here Jaminan Kesehatan Nasional, Prof. So then the poor people can be subsidized by the government, or they can also pay by themselves in terms of the lower cost. It's not so expensive per month. So the BPJS of Jaminan Kesehatan Nasional, one of the program of the government to help the people who cannot buy the medicine. So medicines like for asthma treatment for asthma treatment, for the chronic disease treatment in Indonesia, hypertension, diabetes is free if they are member of Jaminan Kesehatan Nasional. So I also have one question, final question, Prof. Tans. This is like a strategic. So thank you very much for all the participants for that question. The final question from me: how is the implementation of the pharmacoeconomic in your country? What program or what department use this pharmacoeconomic in your healthcare system?
Okay, thank you, Prof. Yusi. So in Malaysia, right now, this one the Pharmaceutical Service Division in Malaysia, this health authority here, the Ministry of Health, they are adopting some similar with this cost effectiveness analysis, but we call it as a budget impact analysis, BIA. For every pharmaceutical company, right? If let's say they want to introduce their medication into the public hospital formulary book, they need to prepare a one budget impact analysis, something similar to the CEA. And then in this budget impact analysis, right, it will be almost same with the CEA, that it need to address what are the benefit, what are the cost saving for the 5 years from the perspective from the government. If let's say the government willing to accept your medication into the formulary book in across all the public hospital in Malaysia. Okay, so from there, in this budget impact analysis, the pharmaceutical company, they need to provide all the detail, the probability, the complication can be reduced, how much can be reduced. At the same time, in the 5 years time, within the 5 years analysis, that this new medication or the new services can help and assist the government to save how much of the cost. Yeah, so this is one of the health economic analysis that has been adopted in Malaysia. So similarly, in another perspective is that we have another one department in the public sector that we call it as a health technology assessment. They're also using this CEA concept to adopt any new services or the new equipment, or like for example, they want to introduce the new vaccination program, like for example, the human papilloma program for the female. Yeah, they also adopted this idea where they will conduct this CEA that design the decision tree within this 5 years. If let's say 70% of the population in Malaysia receive this vaccination, right? In the 10 years, upcoming 10 years, it can reduce the cervical cancer how many percent? Because we understand that cervical cancer, it will incur this chemotherapy cost will be tremendously high. So this health economic assessment team, they will adopt this health economic analysis to plan for it. Whether is it worth it for the government to implement any new services, including the vaccination program. Yeah.
Okay. Thank you very much for your presentation, and also it's a very excellent discussion from the participants. And it's we can know that pharmacoeconomics is one of the important tools for considering cost and consequences, and it's will be used by the government to to maintain the healthcare system in the long term, right?
Yeah.
So thank you very much from Tans for your very excellent and interesting presentations. Now, because the time we already very fast, almost 10 minutes, right, from the hours our plan, but this means your presentation is interesting, and many participants are interested with that. So now we are in the final session. So the final session would be deliver the certificate for you, and we will move to the organizer, the head of the organizer of this event, Ibu Dia Ika. But in my personally, thank you very much for time. So maybe someday we can meet in Penang again.
Yeah,
So,
definitely, Prof.
Yeah.
Okay, welcome to Malaysia.
Thank
Thank you.
you very much. So please, Bu Dia, to deliver the certificate and close the sessions.
Okay, thank you, Prof.
Thank you.
Di sini yang barang kalian muat atau kebudayaan, dan kalian barang pendidikan ya. Oke.
Thank you, Prof. Tanting Siang, for your very interesting lecture this morning. The student is very enthusiastic for this lecture and hope you can if we can meet someday in the other occasion. This is a certificate for you. We appreciate for your lecture today. Thank you
Oh,
very
thank you,
much.
Prof. Dia. Yeah.
Okay, we will go to the closing. Amalia.
All right. Thank you so much, Ibu Dia. What an amazing and insightful discussion. And thank you to the speakers, moderator, and participants that partook in this Q&A session. I believe you guys still have many questions to ask, but unfortunately, we're running out of time today. And next is a handout of certificate of appreciation to our amazing moderator who lead our session properly, to Profesor Dr. Yusi Anggriani, Magister Kesehatan. We also invite Ibu Dia Ika to hand out the certificate.
Okay, thank you, Prof. Yusi, for your time to manage the session of lecture. This lecture, this is our appreciation for you, the certificate. Thank you very much.
Thank you. You're welcome.
All right then. By the marks the end of our lecture today. Representing the committee, I would like to thank to all speakers and moderator, and of course to all the participants that have joined us with this lecture today, truly. We would like to apologize if there's any mistake along the way. Once again, thank you so much for your attention. I'm Amalia Zahra Apriliana as the Master of Ceremony. Wassalamualaikum warahmatullahi wabarakatuh. Shalom, Om Santi Santi Om, Namo Buddhaya, Salam Kebajikan, Salam Pancasila.
Thank
Yeah, thank you so
you.
much.
Goodbye.
Salam
See you.
Pancasila. Thank you, Prof.
Thank you so
Yusi.
much,
Yeah.
Prof.
Thank you, Prof. Dia.
Thank
Thank
you.
you.
Thank you. Yeah.
Bye-bye. Thank you. Bye.